Hi everyone, a very good afternoon to you all. I welcome you all to yet another session of IFS. Today we have with us Dr. Sweta Gupta. Dr. Sweta Gupta is a clinical director and senior consultant in Medicover Fertility, Delhi. Ma'am has done her MBBS and MD in OBGYN from Delhi. She has done her MRCOG and DFSRH from London, UK. Ma'am has done her MSc in Reproduction and Development from Bristol, UK. Ma'am has done her fellowship in Reproductive Medicine and ARP from London, UK. Ma'am is a joint treasurer in IFS from 2020 to 2022. She is an executive member of Indian Fertility Society from 2016 to 2020. She is a member representative of RCOG New Zealand, and ma'am is also an assistant editor of Fertility Science and Research Journal. I welcome once again, ma'am. You can begin with your presentation.
Yeah, thank you, Kathy. Good afternoon, everyone. Today I'm going to speak on anti-Mullerian hormone, AMH, in ART and beyond. So, as we all know, our natural life expectancy has increased to 80s, but when it comes to fertility life, it still ends at 40. So, why is it so? It's because when the woman ages, her ovarian reserve diminishes and the rates of both spontaneous and assisted reproductive pregnancies decline. So, assessment of ovarian response potential before the patient enters an ART program is therefore important. Now, earlier days we used to use age and day 3 of FSH, but with recent advances, we have been using not only antral follicle count but AMH in predicting ovarian response. So let's look into AMH. What is AMH? AMH, or the anti-Mullerian hormone, is a 140 kDa disulfide-linked homodimer glycoprotein and a member of the transforming growth factor B. Now, this specific expression pattern of AMH in growing non-selected follicle has prompted scientists to investigate whether serum AMH levels are indicative for the size of the growing follicle pool. And the direct measurement of the primordial follicle pool is impossible. So, however, the number of primordial follicle is indirectly reflected by the number of growing follicles. And since AMH is expressed by growing follicles up to selection and can be detected in serum, it is a promising candidate in ovarian reserve testing. So as we see in this diagram, it is produced in the early stages of follicle, which is characterized by gonadotropin independent growth, whereas other markers, they are actually dependent on the FSH. The growth is dependent on the FSH. So how does AMH, what is the mode of action of AMH? It is not only produced by small growing follicles, but it has an inhibition effect on the initial follicle recruitment. It also inhibits FSH-dependent growth and selection of pre-antral and small antral follicles. So this is the step one, and here also it has an effect on the pre-antral and small follicles growth. In PCOS, what we see is a very elevated AMH level, and it has been seen that it is associated with abnormalities of early folliculogenesis within the complex PCOS pathogenesis, which may explain why AMH has the potential to be used as a biomarker for the diagnosis of PCOS. Ovarian aging. It can be defined as a period in which there is a measurable decline in the level of circulating AMH and but also rise of AFSH and estradiol. AMH usually increases up to the age of 24 years and afterwards it decreases until menopause. Now, in some studies, it has been seen that the AMH levels in blood drop yearly by approximately 0.3 microgram per liter. So there are different ranges, different units, and the AMH levels the charts are there for the exact age-specific AMH levels. But then there are other biomarkers also. Let's have a quick look on these. There can be a clinical marker like age. Age is considered to be the single most important factor in determining quality and quantity of ovarian reserve. Menstrual cycle, because the length is dependent primarily on the rate and quality of follicular growth and thus the duration of follicular phase. There can be endocrinic other markers like day 3 FSH in intent, and also the endocrine dynamic tests like clomiphene citrate challenge test and exogenous FSH ovarian reserve test, where we give a dose of FSH and then we see how the response is. Then ultrasonic markers like antral follicle count, which is an excellent predictor of ovarian reserve and with significant superiority to other markers, and also ovarian blood flow. But when it comes to AMH, how do we assay? How is it done? Assays for AMH have evolved. There were three commercial ELISA kits which were used to measure the AMH, which differed in their antibody pairs, their standard curve ranges, and also limits of detection. The first kit was introduced in 1999 by Immunotech, and where they used a monoclonal antibody pair and one directed at the pro region and the other at the macro region. Then the second AMH kit was launched in 2003 by Diagnostic Systems Lab, and where both the monoclonal antibodies were directed at the mature region to minimize the proteolysis. Both IoT and DSL AMH continued to be available till 2010 when Beckman Coulter developed a second generation AMH ELISA kit. And it was even seen that IoT assay was 40% higher compared to DSL. So rendering the combined analysis of trials employing different assays problematic. Recently, other commercially available ELISA kits are developed by AMH Labs, and these two kits use the same monoclonal antibody pair directed against specific linear epitopes. There are the ultrasensitive AMH ELISA kit and the Pico AMH ELISA kits. So this is an overview of commercially AMH assays which are available. At present, there are three fully automated immunoassays available on the market which have relatively high specificity and sensitivity. One is the Elixis AMH from Roche, AMH ELISA from the AMH Labs, and Exis AMH from Beckman Coulter. Now, very good study which is published recently in March 2021, where they compared the performance of two AMH assays, Beckman Coulter and Ansch Pico AMH assay. What they demonstrated that despite the high correlation between two commercially available AMH assays, the assay performed in a discordant manner at a very high and a low concentration. And results of these assays are not interchangeable, highlighting the need to establish specific reference limits for individual assays to guide clinical decision making and the challenge of establishing future universal cutoffs for the application of AMH levels in the clinical practice. So there is a difficulty in measuring AMH serum levels is that there is still no international generally accepted standard for sample preparation, storage, and AMHs. The pronounced use of AMH is mainly obstructed by unreliable diagnostics, which is caused by lack of international standardization of AMH assay, which lowers the specificity of the measurements and the clinical use. So international standardization is the most important issue that should be tackled in near future. Now, in 2020 August, Jackie Ferguson, they presented this paper and it was said that it was agreed by the WHO Expert Committee on Biological Standardization to establish 16 by 190 as a reference, WHO reference reagent for AMH with a content defined by consensus immunoassay of 489 nanogram per ml ampu. So in future, we hope that there will be an international standardization and we may have a very specific AMH report. Now, what are the advantages if we compare AMH test with other biomarkers? It has been seen that evidence so far suggests that AMH is the best currently available test in terms of sensitivity and specificity. It is the earliest marker to change with age. It has the least intercycle and intracycle variability. Can be randomly measured during the cycle. There are different areas where ovarian reserve testing by AMH may prove to be distinct clinical benefit, like the fecundity prediction, menopause prediction, prediction of pregnancy chances in couples presenting with infertility, and patient management in IVF. So in this meta-analysis, you can see the AMH has at least the same level of accuracy and clinical value for the prediction of poor response as AFC. Now, when the test optimization was done, then for clinical application, it is more promising for AMH test. This study showed that when we have AMH, the sensitivity and specificity for poor response is 74% and 87%. And for the hyper response, AMH is sensitive up to 94% and specificity 81%. Now, this study by Zehra et al. Compared AMH versus FSH, and then they found that the AMH is superior in clustering study cohort on the basis of antral follicle pool, especially in setups with non-availability of technological expertise to access AFC. So the incorporation of AMH improves the estimation of baseline ovarian reserve required to standardize dose for optimum response and avoiding the risk of failure to retrieve oocyte or inappropriate stimulation leading to OHSS. A very good study by Lamarck et al., which says that AMH appears to be stable throughout the cycle. And this is why we have been able to use it any time in the cycle. But then there are a lot of factors which have been seen to be influencing AMH. So there is variation. Now, the variation in the result of AMH could be physiological, could be pathophysiological like granulosa cell tumor, could be non-physiological like administration of estradiol or progesterone or ovarian stimulation. Variation could be because of AMH in circulation and the sample we take, whether it's a freezing technique, whether it's a tube type, whether the stabilizing reagent we add, temperature variation, physical handling, contamination, hemolysis. Then how we assay AMH. So there could be antibody specificity and sensitivity, so analytical variation. There can be lot to lot variability, uncertainty, intra and inter assay variation, and there could be variation in how we actually measure the AMH. It has been seen that the serum AH levels were higher during the follicular phase than the luteal. So should we be, or the optimal time to measure AMH concentration might be during the follicular. And if we look into the study by Gorkum et al., where it shows that it exhibited great variation in infertile women with different ovarian reserve. In follicular, it is little higher than the late luteal phase. Then comes the ethnicity, and this is so important for Indian because most of the books are Western and the data is Caucasian. So if we look into the recent studies, this is a study where they compared the AMH with a different ethnic group, and this was done in London by Mr. Goody Group. In fact, in their study, they did not find any dependency on the ethnicity, and they said there is no independent association of ethnicity and serum AMH levels in an unselected population of women attending the London clinic. But then there were more studies. This is a Banker study where they said that if we compare white Caucasian and Indian women, and big study where they found that the Indian women had a lower implantation rate and ongoing pregnancy rate was lower. So it was 35.1% as compared to the Western, which is 41.7. So they said that the ongoing pregnancy was significantly lower among Indian ethnic group following the IVF ICSI, which suggests that ethnicity like age is also a major and independent predictor. Now, this is a study which is being published in 2021, very recent study in February, where they compared the ethnicity and race and age-specific variations of serum AMH. They found that according to variations according to ethnicity, race may be dependent because of additional factors like BMI, PCOS, socioeconomic status, environmental, nutritional, But age is a strong component denominator that influences the reproductive life of women regardless of race or origin. So Caucasian women are often the reference standards, and when we compare to them, the AMH was 25% lower in black women. The Chinese women, they were typically higher in AMH up to the age of 25 years of age, and then the AMH levels tend to be less than Caucasian women after age 25. So, in this study of Nelson et al., which was published in 2019, they again studied the ethnic discordance in serum AMH, and they found that the AMH was 28% lower in Chinese population at age of 30, and this decline increased to 79.4% at the age of 45. So they concluded that there were independent effects of age and ethnicity on serum AMH concentration, with Chinese women having a substantially lower AMH in adult life than their European counterparts after age 25 onwards. Environment. So, does the environment affect the AMH? And let's look into the different studies. There was this study by Lamarca in 2020, which she compared elevated levels of nitrous oxides with lower AMH. And they found that the AMH levels were inversely related to environment pollutants like PM10, PM2.5, NO2. And in fact, they had a strong influence of NO2 exposure on AMH and serum levels. So, what they concluded, although the genetic component is highly predictive for defining the ovarian reserve at birth, potentially modified environmental factors could influence the rates of decline in AMH and ovarian reserve during adulthood. This is another study which is from Korea, Hannah et al., which was published recently in 2021 February, and they assessed the association between air pollution and ovarian reserve in young and fertile women. And they also looked into the AMH ratio, which is defined as an observed to expected AMH based on age. And what they found that with the pollution, there is a decrease in 3 to 10% in the AMH ratio. They suggested, or this evidence suggested, that there is a negative association between ambient PM concentration and ovarian reserve, highlighting the potential adverse impact of air pollution on women's fertility. This is a study by Fatima et al., which was published in 2020, where again they studied the association between the pollution and the green space with the ovarian hormone, with the ovarian reserve hormone, and they found an inverse association between the particulate matter and AMH. In fact, there was an increase in serum level of AMH with green space. So this finding supported a beneficial association of exposure to green space and a detrimental association of exposure to air pollution with ovarian reserve. Now let's look into the BMI. Does this affect the AMH? So, increased body mass index is associated with the non dilutional reduction in anti Mullerian hormone. This study was showed that the increasing BMI and waist circumference were associated with reduction in AMH and AMH oblique AFC ratio. What they concluded that BMI was associated with reduced AMH, and the decreased AMH production by the follicle unit may be responsible for reduced AMH with increasing BMI. Another study by Arkin et al., which investigated the association between BMI and ovarian reserve, and what they concluded that the mean random serum AMH levels were 33% lower in overweight and obese women compared with women with a normal weight. They concluded that overweight and obese women with decreased ovarian reserve, as defined by high day 3 FSH levels, have lower serum AMH levels, and the number of oocytes retrieved compared with non-obese women were decreased. This is another study which is by Dragas et al., which published in 2019, and they evaluated the relationship between AMH and BMI. Now, in their study, in fact, it was other way around, and they said the BMI more than 25 was significantly associated with higher AMH in comparison to normal weight patients. So AMH in their study was positively correlated with BMI, and especially in younger patients less than 35 years old. So this data contradicts the previous study showing a negative impact of excess adiposity on AMH serum levels. So we still need many more studies to actually clearly define what is the relation between the BMI and the AMH. Now let's look into the hormonal contraceptions. This is a study by Calillo et al., where they checked the AMH levels at various periods of the administration of contraceptive pills. And as compared to the baseline, you can see at the 5 weeks it has lowered, and it has further lowered at 9 weeks. So, this study by Peterson et al., which published in 2015, they actually compared the ovarian reserve in the users of oral contraception pills seeking fertility advice. And what they found that the ovarian volume was 50% lower, and AMH was 19% lower, and AFC was 18% lower in oral contraceptive users compared with non-users. Comparison of AMH at values less than had a 10 was found to have a significant influence on AMH. So, and what they found that there was actually a shift towards a small sized antral follicular subclass. Another study by Penziman, and where they also compared the AMH concentration and whether it is influenced by hormonal contraception, they found that the users of hormonal contraception had a 29% lower AMH concentration, 30% lower AFC, and 42% lower ovarian volume than non-user. So the study indicated that ovarian reserve markers are lower in women using steroids for contraception, and thus women AMH AFC may not retain their accuracy as predictors of the ovarian reserve in women using hormonal contraception. Vitamin D. So when we look into nutritional vitamin D, the study compared the association between vitamin D and ovarian reserve markers. They used the vitamin D deficit patients' data as well as with the normal ones, and they found that there is no difference. No significant association was observed between the AFC and vitamin D levels. So let's look into what are the uses. The uses are in the IVF treatment, ovarian reserve assessment, individualization of the treatment, the success rate prediction, also in the diagnosis of PCOS, low ovarian reserve or menopause, or even cancer. So, quantifying fertility, a very important day to day use it has become. It checks the biological clock. In fact, it is very popular. It has become a direct to consumer testing. The patient does not even need to go to a gynecologist. They are just going straight for their text checking because of its low cost and widespread availability. It is very helpful for planning their family for the women, even for the single women. It is a simple blood test. It can be done by LGBTQ and different other groups. And a women can plan, and if it is low, then they can have in those women who are even in relationship, they can actually plan their pregnancy. And if they don't want to get pregnant, then they can even go for egg freezing options. So there is an influence of AMH on IVF success, and in this study by Gomez et al., they said that it's a very useful parameter that should be measured before performing an IVF. In younger patients, AMH levels do not predict pregnancy outcomes, but in patients older than 36, AMH can be used as a prognostic factor. And even when a woman's AMH are too low to be detected, she still has an acceptable chance of becoming pregnant. So IVF outcome of women with discrepancies. So sometimes in a clinical practice, we see that the age and the AMH level is not matching. In this study in the Zhang et al., when they reviewed, they found that even young low AMH group showing a poor ovarian response may have actually a better clinical pregnancy and live birth rate. However, the cumulative clinical pregnancy and between the two groups, younger and the older, they were the conservative, the discrepancy increased until the third embryo transfer and then reached a plateau thereafter. There are some roles of AMH in other gynecological conditions like tumors and cancer. It has been seen that the higher concentration of AMH is in tumors of granulosa cell tumor because of increased amount of AMH into the bloodstream. And also the same positive association of high circulating AMH is seen in the breast cancer. Patients who have been treated with Hodgkin's disease may have lower AMH and lower ovarian reserve than the healthy women. So in particularly granulosa cell tumors, it is increased in 76 to 93% of women with granulosa cell tumor, and elevation of this level precedes the tumor recurrence by up to 16 months, and it can be an early marker for granulosa cell recurrence. Now, whenever we have a cancer treatment, whether chemotherapy and radiotherapy, we all know that it can affect the ovarian function. So, AMH can be used to assess ovarian function after chemotherapy or radiotherapy in young women. Uh, there is a study in the Hodgkin's lymphoma where this AMH test is used to assess the ovarian function, and it demonstrated a clear-cut dose-related fall in AMH concentration in relation to the number of chemotherapy cycles. So if you see this graph in the blue color, the patients who use the ABVD regime, the initial AMH was higher, which was a pre-treatment, which they were after 2 cycles it dropped, and end of the treatment it little bit picked up, but with 2 years it got better. This is a low risk AMH, low risk chemotherapy, whereas on the other hand, the red one is another regime which was actually quite detrimental with the ovarian reserve, and this is depicted here in the red color. The another use of AMH which we have been talking about is the prediction of menopause. So can a single AMH measurement be used as a good predictor of the onset of menopause in aging women? And if this is correct, or if they can give the correct prediction of age at menopause, it could open avenues of individualized prevention of age related infertility and menopause related conditions like cardiovascular disease and breast carcinoma. In POI, premature ovarian failure, there has been noted that the natural menopause occurs because of the mutation of the gene AMHRIA, and it happens that they stop working earlier than what we expect. So the AMH, can it actually accurately predict the menopause? In this study by Martin et al. In 2016, they found in a single study it showed a promising contributor to AMH for menopause prediction. But when they looked into the other studies, the whole model, however, did not predict the extremes of menopause age very well and have wide prediction interval. So these markers clearly need improvement before they can be used for individual prediction of menopause in the clinical setting. There was another study which said, okay, instead of one AMH, we'll look into the multiple AMH measurements. And they looked into about 2,400 premenopausal women. And what they found that for a woman who's younger, less than 30 years, for whom menopause prediction is arguably most relevant, the model underestimated the risk of early menopause. So, in overall, they concluded that these results results suggesting that the knowledge of AMH decline rate does not improve the prediction of menopause. So, the use of AMH as a screening method for timing of menopause cannot currently be advocated. Ovarian surgery, we all know that it reduces the ovarian reserve and which we can assess by the AMH. This is a beautiful paper by Chen et al. Where they looked into the endometrioma group and what they found that they actually have a lower AMH levels. They were much lower as compared with other benign ovarian cysts, and the rate of serum AMH decline was 1 month a decline 1 month after surgery in the endometrioma group was larger than the decline in other benign ovarian cyst group. The preoperative AMH levels showed a significant correlation with the patient age, and the rate of serum AMH decline was larger for bilateral endometrioma and in the subgroup, which was more than 7 centimeter and higher. Now, there are some experimental uses which have not yet become day to day use, but this is a beautiful study by Zhang et al., where they compared with the recombinant AMH could be used as a compound added to the in vitro maturation, and where actually this can be used for improving the quality, and we can get the better quality of embryos after in vitro as fertilization. So they added 100 nanogram ml of recombinant AMH to the IVM medium, and which showed their improvement. Of course, we need more studies before this becomes a day-to-day practice. Contraception, administration of recombinant AMH in human ovarian tissue in vitro has been shown to suppress the initiation of primordial follicle recruitment. Although other studies may claim opposite, but this showed that it is a way of reversible contraception to halt primordial follicle recruitment, and with this delay the onset of menopause. So, as a contraception, AMH could prove invaluable in fertility of women with lower ovarian reserve at a younger age, as well as becoming a more natural and non-invasive means of contraception in comparison to currently available substances. So, in summary, AMH is still the most single best blood marker for assessing the quantitative aspects of ovarian reserve and managing ovarian stimulation. Some studies continue to demonstrate a helpful age-independent association of AMH with qualitative aspects of ovarian reserve, such as egg quality and live birth and time of conception, but this association is weak to moderate at best. Clinical studies now support expanded clinical application of serum AMH testing, like in the prediction of menopause or the monitoring of ovarian effects of the medications and surgical procedures, or evaluating the risk to a variety of disorders like PCOS, POI, POF. But what is most important is caution. Caution is required when we are interpreting a single AMH measurement because biological fluctuation, surgical procedures, and medication, example contraceptives, and lab methodology, can frequently lead to dramatic changes in AMH results within individuals. So, some steps are recommended to account for variability in AMH results. And if we look into this beautiful chart or the checklist, which can help all of us to maximize the clinical utility of AMH testing, the first is use one lab calibrated to outcomes. So you avoid mixing and matching values from different labs and identify a single reliable source for testing which both calibrates the results to the clinical outcomes of interest and commits to updating the clinician if calibration of the results changes. Second, utilize more than one ovarian reserve test. Avoid using a single serum AMH measurement alone to assess ovarian reserve. Incorporate other markers such as AFC or an early follicular phase serum AMH. Identify exposure. So that means identify whether the patient has taken medications in the history, check whether there is a history of hormonal contraceptives, whether there has a history of cancer, chemotherapy, and also any surgery, ovarian cyst or endometrioma removal, because all of these that can affect the AMH levels. Counsel the patient, which is very important and which we sometimes don't do, but this is the most important, that prior to testing, verify the patient's understanding the directional nature of the information being provided by AMH testing, and that in a subset of women, the test result may change substantially with biological fluctuations. In such cases, consider retesting. Because if testing results lead to life changing decisions, or if the results are inconsistent with the clinical scenario, consider retesting. So many improvements to the management of women's health are possible through appropriate AMH testing. However, variability in AMH results can lead to clinically significant variability in AMH results, making careful approach to the interpretation is essential. And within the above simple steps, a clinician can rapidly minimize the risk of incorrect interpretation. I think we will end the session. Khyati, so we will start with some question answers.
Yes, ma'am, we can start with the question and answers. And thank you so much for the beautiful presentation.
So
Yeah,
we have
ma'am, you
lots
can
of
just.
questions. So let's start.
Yes.
Sorry, yeah, Khyati, just say that again.
No,
Are
ma'am,
you
you can begin
am
with
I
the question.
audible?
Yes, yes, ma'am, you're audible.
Okay, so we have a yeah. So we have a question here which says that can AMH determine quality of follicles or just quantity? So as I have just mentioned that there are many studies which are saying mainly the quantity, but there is some evidence which may say that it is the quality. But again, this is not a very good evidence there is that it will tell the quality. So we should be very much, we have to consider the other parameters, especially the age. And it has been noted that if we have a younger lady, even with a lower AMH, she may actually do better than the lady with the better AMH and a older lady. So you have to take a complete picture in totality, and just cannot rely only on the AMH level. The next question is by Dr. Yash, which says that which ovarian stimulation method to use according to AMH level. So now this is, again, it depends on what you are going to, what you are going to do as a treatment option, what is the patient's age, what is the previous treatment, what she has taken, and then decide, if suppose she has a very high AMH, then she is a PCO patient, we may start with a very low dose. We may use the antagonist protocol in IVF if we go, and we may go ahead with the free zone. So it actually depends, yes, and but it is helpful. The level of AMH is helpful in programming, in starting as, especially as a first dose. When you start the first dose in IVF practice, if you look into the age, you look into the AMH level, if you look into the other parameters, if you have a day 3 FSH level, and also previous treatments, you will, the AMH itself is very helpful in deciding the first starting dose. Of course, when you see after 5 days or 6 days, you can always you see what is the response of those starting dose, and you can make the adjustments and change accordingly. So now the next question we have is, can AMH value be directly related to the AMH ART outcomes? Yes, we do have some studies where we can predict, but again, there was one study which I showed, which is that sometimes this prediction is not always right, and if the lady's age is young, then it may, even if there is a low AMH, it may have a better outcome. So we cannot entirely depend on the AMH. There is no need, even if there is a low AMH to go straight away on the other options like donor. Even if it is low, I think it's very fair, and as per evidence, that she should try with her own egg stimulation uh, uh, rather than jumping on the other options. So there is a question by Dr. Deepak that what about predicting hyperstimulation? So usually this is seen in PCO patient, as I have already mentioned in my presentation that uh, when the level is more than the normal, it's a biomarker for PCO, and the PCO patients one has to be very careful. Yes, AMH can help us in predicting hyperstimulation, and we should be careful with the stimulation protocol. Start with the low dose, maybe use antagonist, and slowly increase the dose, because they have a lot of follicles and they suddenly can become big, and there can be hyperstimulation. So very close and careful stimulation, but yes, AMH can be helpful in starting the dose and sort of close monitoring thereafter. So now we have we have a Anchal Gupta. Does AMH increases pre-menopausal? Does AMH increase? So normally there is a ovarian reserve has a, graph, which we all know that initially it is it increases up to 24, 25. So mid 20s it has been shown to increase, the AMH is increasing, and thereafter there is a gradual decline, and after 35 we have seen that it may drastically drop, and the AMH level go down and reaches low with 40 and thereafter. Now, what happens to AMH in PCOS? I think we have already answered that the PCOS, they have lot of follicles and they have a high AMH levels. So there is a scenario which is by Shalini from Ganganagar, where she has written there is a 38-year-old female with 2 failed IUI in an AMH of 0.7, and oligospermic diabetic husband should go for IVF. Yes. So why not? I mean, she has tried with IUI. If it's not working, and because it's her age is 38, she and the AMH is low, 0.7, then we would like to fast track her treatment, and the IVF is way forward, and she should try with her own eggs. Of course, for that we will do an assessment. We will also see into the how many follicles, like antral follicle count she has, and and of course the sperm assessment. There are some sperms. The diabetes has to be controlled, but overall, yes, of course, why not? ICSI is can should be done with her own eggs first. Now, then we have. There is one question from Dr. Shashi Mumbai. Is it possible that even if the image is low, there are women in which considerable number of eggs could be obtained in response to ovarian stimulation? Yes, this is possible. So, as I have seen, that just don't go by single AMH measurement. Uh, if you find it is low, please look into the other aspects, which start from the history. What is her age? What is, whether there is any high risk factor in her age, whether there is a history of surgeries in the past, or what is the reason why the AMH is low. And if we have seen that it is not we may have to reconsider retesting and check with other and it is always appropriate to go ahead if you see some follicles on the antral follicle count, and then to go ahead with stimulation with her own self eggs, and you may find that you get decent number of embryo of eggs, and also pregnancy. Can AMH, that's a Dr. Rucha from Mumbai, can AMH concentration predict poor response to controlled ovarian stimulation during IVF procedures? Yes, if the AMH is low, then it can predict the poor response. So it has been used as one of the predictors for the response, AMH. So this is now there is a question which says that if AMH is more than 15 and not responding to gonadotropin, what next? So if AMH is more than 15 and it's higher than the normal range, it you have to again look into the history. It can be a like PCOS, and in that case you have to again check with the ovarian with an ultrasound and see what the follicles are look like. And if you feel it is a PCOS, you may have to change little bit stimulation technique. If on the scan you find a PCOS picture, then start with the low dose and gradually increase the dose of gonadotropin. Majority of the cases we have been able to increase the with the dose. Sometimes we may have to add not just simple FSH, a little bit of LH, or maybe steroid. But this depends upon what how the protocol of stimulation is. And in those cases, you may have to increase the dose and go little prolonged with little prolonged stimulation. And the it is seen many times that the even the E2 levels also goes very high. So in such cases, then after taking out the eggs, it's better to do the freeze-all and then only go ahead with the segmented or the frozen embryo transfer in such cases. Is there any more question, Khyati?
So, ma'am, all the questions are there on the sheet. If you want, we can just wait for a couple of more minutes.
Yeah.
Ma'am, till that time, if you would like, if you would like to give a take-home message to the audience.
So the I think it's very important that we counsel the patient appropriately before doing this AMH test. We must remember that and tell the patient that this is gives some idea, because sometimes the patient gets very unexpected results, and they really go into a lot of psychological stress, especially nowadays when the women are marrying late or they're planning pregnancy late. So of course this is a good it quantifies the fertility, and it's quite useful as a day to day basis, that you need to when you need to plan your baby, you shouldn't be delaying too much. Or if you don't want a pregnancy, then you must realize that there are options nowadays where you can even go ahead with the egg freezing. So it's a very good test, but as a clinician, you must look into the other pictures, because just on one test you should not be making the decision, especially when it is extremely low, and we have other options of IVF treatment. Shouldn't be jumping into the donor or other options. Should look into and give a good try with the first with her own self egg stimulation. So I think this is very important, that interpretation of the result is extremely important. So doing the test, and of course interpretation with the so that we can use it clinically, optimize the IVF results, and also the right way of treatment. Because sometimes AMH may be little low, but young patient, she may you do IUI 2 cycles, she may conceive in that. But rather than jumping into straight away into some other options, we should be very holistic, complete approach, and looking into other aspects also. So there is one more question: what are the possibility of normal AH and low antral follicle count? How much they are correlated? Yes, this can happen. And in day-to-day practice, you will find that sometimes the image is normal, but when you scan that lady, you find that the follicles are very few. So that is why the even the assessment, the commercial tests which are available nowadays, they are not actually that accurate as we would like it to be. So the international standardizing and different commercial kits may have variations. So one test should not only make us just completely rely on that. If you do your own ultrasound, see what follicles are, but go with the. Sometimes I find it very handy to go by the what I see in the ultrasound and take a decision based on that. So these inconsistencies, these are there. So AMH as a blood test, it only guides us. But again, I'm saying this, that please consider the age, the lab. There is very clearly, it is there are studies where you find that there are differences in the different kind of labs and different specification. They may not match exactly. So age, history, duration of infertility, and what all she has already had, see everything together and then take a decision and discuss the options with the patients and then go ahead.
Thank you so much, ma'am. That was a wonderful lecture. Thank you again for your time.
Kathy, thank you very much. Do we need to take some more questions or what MCQs or something?
No, ma'am. And
Okay, so